Thank you, Dr. Herbanslal, for inviting me to be a part of your team for this wonderful course. And what I will be sharing my views regarding the hydro procedures. Dr. Shroff has said that the Rexis is important, a very important part. But I will say that I believe that each step, right from the incision to the oil insertion, is important in the perfection of the phacosurgery. Now there are two things, hydrodissection and hydrodelineation. Now, if you want to have a very good hydrodissection, you must look for the certain signs. Like when you're doing it, make sure that you see this fluid wave going behind the lens, behind the nucleus. Then, if you go further, you may find the splitting of the anterior lens fibers. And sometimes when we are going ahead, the red glow will disappear. It will become faint, and probably the nucleus will bulge into the anterior chamber. Not only that, at times you will find the golden ring. Now, all these signs, not necessarily you will see in each case, but if you see even one sign, that you are sure that the hydrodissection has been done well. And when there is a corticocapsular adhesions, then not necessarily you will find. You will have to do hydrodissection at multiple places. The Rexis margin you can see here, at times you will find that it enlarges, becomes a little prominent. Now, hydrodissection, how does it help? It will help to allow the rotation of the nucleus. Now, this rotation of nucleus will reduce the risk of zonular dialysis, reduce the risk of posterior dislocation of the nucleus, reduces the chances of PCO, because the equator of the lens nucleus will clean the lenses at the equator. Now, during these steps, there will be debulking of the nucleus, which will reduce the phaco time, reduce the irrigation aspiration time of the cortex. Then, if you have the large epinucleus, then it will keep your capsular bag stretched. There are less chances of PCR. There will be less chances of capsule or zonular rupture. At times, you cannot do hydrodissection. It's very lethal. You can end up in the complications, particularly in the posterior polar cataract, because the posterior capsule at that point of capsule is very weak. And this hydrodelineation, where you have to go into the lamelles, which prevents PCR, and the rotation of nucleus may not be, you cannot do that here. And once you remove the nucleus, there is a very large amount of epinucleus which has to be removed. Now, this cortical aspiration, the cataract has been removed. So that step I am skipping because somebody else is taking over. Now we have to remove the cortex. Now we have two things, either the coaxial probe or the bimanual cannula. When you use coaxial probe, it has very good, there are certain advantages, because it is easy to remove epinucleus when you have a large amount of cortex. The small nuclear fragments, suppose they are left out somewhere, then with these probe you can remove easily. IA time is less. Vacuum can be adjusted, and because machines are programmed. And posterior capsular polishing is very, very easy and very effective. You can see here, there are some fibers attached to the posterior capsule. You have to turn your probe posteriorly, and you can remove it. You can see on the side, right side of your the thing, the vacuum is between 0 to 5, because they are programmed. Only thing you have to take care that you move fast a little bit, and if the capsule is very, very fragile, maybe you have to skip that at times. However, there are limitations of the coaxial probe. The pupil need to be better dilated or fully dilated. When it is small, it is difficult to remove the subincisional cortex, and it is difficult to polish the posterior surface of the anterior capsule. So there is another methodology, this is bimanual cannula. There are advantages, because the AC chamber remains more stable, and particularly it is better when the cortex is less, pupil is getting narrower, and to remove the subincisional cataract. And the polishing of the posterior surface of the anterior capsule is easy here. However, there are limitations, like here, It takes more time for the epinucleus or the large amount of the cortex to be removed. Cannot remove the small nucleus fragments easily. Difficult to polish the posterior capsule because the port of the cannula cannot be turned posteriorly and machines are not programmed. But at times we have to use both. You can see here on the left, the pupil is getting narrower, but there is a very large amount of cortex. So you can use coaxial here, and once the major part is removed, for the subincisional, you can use the irrigation bimanual cannula. Like the right side of yours, you can see here the large amount of cortex. There is no need to use bimanual. You can use the coaxial probe, which is very easy. You can remove them very efficiently. You can see here on the left, the subincisional cortex is very easy to remove with the bimanual. However, there are certain tips I would like to share with you, that when you want to inject visco in the chamber, make sure that you inject through the main wound as much as possible. Keep the posterior tip of the wound a little depressed so it is not over formed. Avoid the side port for the visco insertion and avoid 100% formation of the chamber. Avoid forceful rotation of the nucleus. This is very dangerous. You can damage the zonules. Avoid iris and rexis margin tuck. And be careful while you are at the periphery. And if it's necessary, as I mentioned earlier, you have to use both coaxial as well as the bimanual for the irrigation and aspiration. Thank you very much for your time, sir.